This meeting is being recorded.
Back to School Wednesdays, we have the case discussion series, Learning from Little Ones. And we are going to walk down a less traversed path today. And for a change, instead of the postgraduates, today our own faculty is going to present. And he's Dr. Suman Das from Kolkata. Sneha, please. Okay. He's a consultant pediatric neurologist from Bangalore Institute of Neurosciences and BC Roy Postgraduate Institute of Pediatric Sciences, Kolkata. And he's involved in multiple research works, including pediatric stroke, encephalitis, demyelination. And he has authored more than 38 publications and is a speaker for many conferences. And today he'll be presenting interesting cases. And to discuss the cases, we have two more experts with us who need actually no introduction. They are well known to all of us. Welcome, Professor Shefali Gulati, Professor and Chief of Child Neurology Division, Department of Pediatrics, AIMS, New Delhi, and Dr. Maya Thomas, Professor and Head, Pediatric Neurology Department, CMC Vellore. So over to you, Dr. Suman. You can start your presentation.
Good evening, everybody. At the onset, I want to thank today's chairperson, Dr. Sridharan, for introducing me and for choosing me as the speaker for today's evening press presentation. And as already mentioned, I have two extremely eminent professors, Dr. Maya Thomas and Dr. Shefali Gulati, as the experts of today's case presentation. And I want to thank both of them for accepting my request of being the expert for today's case discussion. I would request their permission to start my presentation.
Please start, Dr. Suman. Dr. Maya, you can start, right?
Yes, please go ahead.
Okay,
all the best wishes.
Thank you. The first case is a 2.5 years old girl who had presented with fever, a right forehead abscess, and right ocular pain with progressive swelling and redness over the past 5 days. Now, the fever was initially low grade and intermittent fever, but then it became high grade continuous. And she developed a swelling and redness over the right forehead, with gradually increased in size, and it spontaneously ruptured 4 days later, discharging pus. So it was an abscess over her forehead. And 2 days after the appearance of the abscess, she had a right eye pain, swelling, and redness. And she had a mild developmental delay in the gross motor, fine motor, language, and personal social domains. Now, the examination in the general survey, she had mild malnutrition, she had pallor, she had signs of infection, she had tachypnea, tachycardia, fever, and bilateral submandibular lymphadenopathy. Now, ophthalmological, she presented to the ophthalmology department, and the ophthalmological examination showed that she had ptosis, hypotropia, and loss of abduction of the right eye. But the other cranial nerves were normal. Her vision was normal. Her pupillary light reflexes were normal. Now, the provisional diagnosis there was right-sided orbital cellulitis. She was admitted and started empirically on injection amoxicillin and clavulanate. But after 2 days after being admitted in the hospital, she developed left-sided hydropneumothorax and severe respiratory distress, and it was treated by intercostal tube drainage. Now, soon after admission, she had anemia. Hemoglobin was 9 grams per deciliter. She had leukocytosis with 16,000 count, total leukocyte count, and there was neutrophilic predominance of 80%. She was negative for COVID-19 RT-PCR. Her blood culture and pus cultures revealed methicillin resistant Staph aureus. And so she was fulfilling the criteria of disseminated staphylococcal disease because she had multifocal involvement of greater than 2 distant tissues, that is the skin, orbits, and lungs, and she had growth of Staphylococcus aureus from blood. So the antibiotics were upgraded to injection vancomycin 40 milligram per kg body weight per day, and she had rapid improvement after that. And over the next 3 days, her febrile spikes reduced, her ocular pain and chemosis reduced, and there was resolution of her respiratory distress. Now, 8 days after her starting of her illness, she has suddenly had a left-sided focal clonic seizure and with rapid secondary generalization. There was status epilepticus, and so she was shifted to the PICU, and the status epilepticus was controlled by injection midazolam and levetiracetam. But she did not need any inotropic or ventilatory support. After the resolution of her seizures, she was found to have left-sided hemiparesis and deviation of the angle of mouth to the right. Now, after control of her seizures, she was shifted out of PICU, and injection vancomycin was continued, and levetiracetam syrup was continued, and her physical rehabilitation was started. Now, to analyze her symptoms, her left-sided clonic seizures, it could be localized to the right primary motor cortex in the precentral gyrus of the frontal lobe. And her left hemiparesis with left UMN facial palsy, it could be localized as a subcortical involvement with corticobulbar and corticospinal tract involvement in the right internal capsule. The temporal course of her neurological symptoms were acute onset, and it was non-progressive. And since it was from all the neurological symptoms followed her orbital cellulitis, the most probable etiology was post-infective complications. It could be meningitis or multiple cerebral abscesses. It could be cavernous sinus thrombosis, because orbital cellulitis, they're prone to have cavernous sinus thrombosis, and since the dural venous sinuses, they're valveless, the cavernous sinus thrombosis could spread to cerebral venous, the superficial cerebral venous sinuses or the deep cerebral veins, and that can lead to venous infarcts and her seizures and hemiparesis, or it could be post-infective arteriopathy. Now, the investigations revealed that CSF had 10 mononuclear cells per cubic millimeter, glucose was 64 and protein was 35. Her echocardiogram revealed that there was a 2 millimeter ostium secundum AHD with left to right shunt. There was no evidence of pulmonary hypertension or no evidence of infective endocarditis. Now, her CT scan, the non-contrast CT scan, it showed that there were gyral pattern hyperintensities in the right frontoparietal cortex. The hyperintensities were following the gyral pattern. The contrast CT scan showed that the same areas of the gyral hyperdensities, they were enhancing on a contrast study. Now, the differentials for these gyral hyperdensities, which were enhancing with contrast, were it could be infectious and inflammatory pathology due to cerebritis, it could be post-seizure due to vasodilation in the post-ictal state, or it could be vascular due to subacute infarct with either luxury hyperperfusion or cortical laminar necrosis. Now we proceeded to the MRI. The MRI, this MRI was done about a week after the CT scan had been done. The gyral hyperdensities, they were present, but to a lesser extent than it was seen previously. Now, a prominent hyperintensity, T1 hyperintensity, was seen in the caudate nucleus and in the putamen. Now, in the high cortical areas, in the subcortical white matter, there were gliotic areas, which were suggestive that there was some pathology which was continuing for quite some time, and hence the gliosis has appeared. The T2 images, it showed that there were along the gyri in the right frontoparietal cortex, there were T2 hyperintensities. And this T2 hyperintensity along the gyri, it is very suggestive of a cortical laminar necrosis. In the frontal subcortical periventricular white matter, there were hyperintensities. There were also hyperintensities in the caudate nucleus and also in the putamen. There were hyperintensities also involved the right anterior limb of the internal capsule, the genu, and also the lesion was abutting onto the posterior limb of the internal capsule also. Now, the T1 contrast images showed the same contrast enhancement along the gyri, where the non-contrast images had shown hyperintensities, and there were also contrast enhancement in the periventricular region. This is a coronal cut where the frontal this contrast enhancing gyral hyperintensities could be seen. Now the DWI, it showed that there was a periventricular and caudate area. It was showing a DWI restriction. There was a corresponding ADC reduction in this area, but the GRE did not show any evidence of hemorrhage. Now, this orbital CT, it showed that there was a circumscribed area of a circumscribed loculated area which was mainly in the superior aspect of the globe. So this was inferred as a right-sided superior rectus abscess. Now, the orbital MRI, it showed that there was hyperintensities in the orbit, in the extracornal pad of fat, and these hyperintensities they showed post-contrast enhancement, and the superior rectus abscess was also well delineated. Now, since I'm reverting back to the images, here at the initial CT scan, it showed gyral hyperintensities. The gyral hyperintensities were persistent, although in a limited fashion in the MRI, which was done about a week later than a CT. The basal ganglia, it was in the periventricular area, they were showing hyperintensities now. There were chronic lesions in the superficial white matter. There was the T2 showed features of cortical laminar necrosis, and the DWI showed an acute lesion. So there were lesions which were of various ages. There were acute lesions, there were subacute lesions, and there were chronic gliotic lesions which were present in the subcortical white matter. So all these features, they pointed towards that there was a vascular pathology which was continuing for quite some period of time, and that resulted in the vascular lesions of varying age, acute to subacute to chronic. So we went for an MR angiography, and this MR angiography showed that there was a pseudoaneurysm which was present in the distal part of the petrospore segment of the right-sided internal carotid artery. It was 2.2 millimeter, and it projected from the lateral wall of the internal carotid artery. Now, in not only the right side, but the left-sided internal carotid artery and its branches, they were showing irregularities. So there were bilateral irregularities, although the pseudoaneurysm was formed on the right side. Now, we went for a vessel wall imaging, which showed that there were a concentric enhancement of bilateral internal carotid arteries. The right-sided enhancement was more than the left-sided enhancement, and the wall thickness on both sides were 2.2 millimeter. So there was vessel wall inflammation on both sides. So since the child had a disseminated staph infection, we went forward to investigate for any congenital immunodeficiencies. The serum immunoglobulin levels were normal, the complement activity CH50 was normal, and the lymphocyte subsets levels were also normal, and she was HIV negative. So we could not find any congenital immunodeficiencies which could have predisposed her to the staph sepsis. Now, considering the possibility of the mycotic aneurysm, the injection vancomycin was continued for 6 weeks. There was the complete resolution of her orbital cellulitis, and her hydropneumothorax had also resolved. The bilateral, the equal vesicular breath sounds and auscultation, and she was discharged on aspirin 5 mg per kg, ranitidine, levetiracetam, and the advice of physiotherapy. And 3 months later, her angiography showed the resolution of the pseudoaneurysm. But at discharge, she was having residual hemiparesis, about 3/5 power. And at discharge, there was residual esotropia and residual ptosis in her right side. And we diagnosed this case as right orbital cellulitis with infection-associated vasculitis with right ICA pseudoaneurysm and ischemic strokes. The current image, the ptosis has improved. There was no esotropia now. And the current CT scan, it showed that in the right frontoparietal cortex, there is evolving gliosis in the cortical area. The subcortical area has already been gliosed, and there is hydrocephalus ex vacuo, resulting in the dilatation of the frontal and the temporal horns of the lateral ventricle. Now, this orbital cellulitis predisposing to internal carotid artery pseudoaneurysm, it is a very rare phenomena. Previous case report, a pediatric case report, was reported from India, and there were 3 adult case reports who have reported infectious carotid artery aneurysm following orbital cellulitis. Now, the review of literature showed that whenever there is an unilateral arteriopathy, at a median follow-up age of 1.4 years, 6% patients, they develop progressive disease. And now 94% cases, they did not have progressive disease. They were classified as transient cerebral arteriopathy. Among them, lesser percentage had complete resolution. Our case had also complete resolution, but higher percentage of patients had residual arterial abnormalities. Among them, 45% improved, and there was stabilization in the rest, 32%. Now, coming to the second case. The second case is a 4-year-old girl.
Dr. Suman, before going to that,
Yes,
there is
yes,
one
ma'am.
question in the chat box by Dr. Sridhar Joshi. He is
Yes, ma'am.
asking the flare as well as T1 chronic infarct appearance. He has some query on that. Yes, what he has mentioned is chronic infarct appears as a flare image and not T1 as mentioned in the slide. That is his comment, but I also didn't understand what exactly he meant out of that. But can you
Yes,
just
madam.
explain?
I am explaining. In the chronic infarcts, they appear hypodense both on T1 and on flare. In the flare images, the CSF is made black. So the gliotic areas, they have the same intensity as the CSF. So this is a T1 image, but the flare image will also have the similar type of appearance of hypointense lesions. The chronic lesions, they appear hypointense both on T1 image and also on the flare image. I have put a T1 image here, but flare image will also show similar type of hypointense lesions for chronic infarcts.
Okay, you can go ahead.
Suban, I have one more comment. So,
yes, madam.
In the beginning, you said the child had orbital cellulitis, and
Yes,
at that particular point, there was associated redness, and there were some eye findings, isn't it? You mentioned
Yes, madam.
some. Yeah.
Yes, madam. There was there was
you said there was ptosis
and loss of
at that
abduction.
particular point was an imaging done.
Because, not at that particular point of time. The imaging was done much later, because at that time the diagnosis was only orbital cellulitis. The imaging was done only when the patient developed neurological symptoms. She had a dramatic course, she had status epilepticus, and after the control of her seizures, only then a CT scan was done.
Yeah, see, what I wanted to say is that when you have a focal neurological deficit, when a child has orbital cellulitis, either this could be either mechanical or it could be a true paresis. So maybe, an imaging at that particular point, and maybe starting of some antiplatelet agent, whether we could have prevented the, progression of that infection-associated thrombosis and stroke is what I was, wanting to comment.
Yes, madam. Madam, see in the initial case, initially, whether the ptosis, the hypotropia, and the loss of abduction, they could be due to the involvement of the muscles, extraocular muscles, due to the orbital cellulitis itself, or they could be due to the nerve involvement. But at that time, the imaging was not done. The imaging was done later. And the imaging, it showed that there was an inflammatory lesion, there was a superior rectus abscess. So a mechanical cause of this hypotropia is present. But on all cases of orbital cellulitis, they do not cause infectious vasculopathy. So initially, we did not even think that this orbital cellulitis, they could complicate to have an arteriopathy. So unless and until the arteriopathy appears or there is some complication of orbital cellulitis appears, before that we cannot add any antiplatelet. Only when we found that there was this arteriopathy, only then after that we added the antiplatelet. We cannot anticipate that whether this case of orbital cellulitis will have any complication or not, because promptly the antibiotics had been started. Only when she developed the complications, only then we went for further imaging, and when that showed that there was arteriopathy, we started that. Is that clear, madam?
Yeah, but I still feel when you have a focal neurological deficit in orbital cellulitis, we should still look for a cavernous sinus thrombosis.
Madam, in this
you can
case,
go ahead. You can go ahead. You may go ahead. Yeah.
In this case, madam, there was no cavernous sinus thrombosis. The cavernous sinuses were clean in this case, but the next case, there was a problem. Here, madam, here the cavernous sinuses, they are absolutely normal. Here there was the flow voids of the internal carotid arteries, they are also present. The lateral wall of the cavernous sinuses, they are also normal. And there is also no superior orbital venous, the engorgement. So here the cavernous sinuses are normal in this case. Here the case was the internal carotid arteriopathy post orbital cellulitis.
Yeah, please go ahead. Yeah.
So the second case, it was a 4-year-old girl. She had normal growth and developmental parameters, and her problem started again with fever, which was initially low-grade intermittent and later high-grade continuous. She also developed pain and swelling in the right eye 1 day after the onset of fever. She was initially seen by an ophthalmologist and prescribed oral antibiotic cefuroxime. There was no remission of fever, and there was increasing right eye pain and swelling. But 3 days after the onset of her illness, she started to have a focal left-sided seizures, initially with preserved consciousness, but later she had generalized seizure. She was initially admitted to the local hospital, but later referred to her nearby medical college. And the initial part of the treatment was done at that local medical college with the Malda Medical College. And after her initial focal seizure, she had generalized seizure, repeated episodes, and so she was shifted to the PICU. On the same day, there was swelling and congestion of the left eye also. Initially, it started with the right eye. Now the left eye also was involved. The seizures were controlled with IV medications, and there was no need of any ventilation. In this case also, the blood cultures drew Staphylococcus aureus. Now, upon seizure control, her mother noticed that there was an eyelid drooping and squinting and paucity of movements of both her eyeballs. And there was also a reduced movement of her left upper and lower limbs. At Malda Medical College, she received antibiotics for 4 weeks and then discharged and referred to us for further evaluation. But the patient did not come early. She came here 11 months later. Now, to analyze this case, her left-sided focal clonic seizures, it was localized to the right primary motor cortex. Her left hemiparesis. Now, in this case, there was no history. The mother did not give any history of facial deviation. So this left hemiparesis could be due to some cortical lesion, or it can be due to a subcortical lesion. And the development of a left ophthalmoplegia, it could be due to the spreading of an infection. It can be due to the spreading of infection and resulting in bilateral orbital cellulitis, or it could be due to the spread of the infection and development of cavernous sinus thrombosis. Since again in this case, all the neurological complications occurred after the appearance of orbital cellulitis, here also we considered the etiology to be a post-infective complications of orbital cellulitis. Now, when she came to her almost a year later, she had higher mental functions. She had bilateral restricted abduction. Other cranial nerves were normal. She had a left-sided hemiparesis. The power was 4-5 with Briggs jerk and extensor plantar on the left. There were no sensory or cerebellar abnormality, and she had left hemiparetic gait. Now, these were in her initial images. The T1 image showed an ill-defined hypointensity in the right frontal cortex. There were ill-defined hypointensities in the subcortical white matter also. Now, the T2 image, it showed in the corresponding area, they were showing a gyral pattern hyperintensity. Here, there is a gyral pattern hyperintensity seen in the T2 images. The T2 flare is also showing this hyperintensity in the right frontal cortex. And there were also, on the left side also, in the subcortical area, there were T2 flare hyperintensities. Now, the DWI, they were showing restriction bilaterally in the right-sided in the frontal cortex, and in the left side in the subcortical white matter. There were bilateral DWI restriction. And an interesting thing was that apart from the frontal cortex, there was a DWI restriction in the occipital cortex also, in the parietal area, and also in the occipital area on the left side. She also had a DWI restriction. Her ADC images showed a corresponding reduction in the ADC values in the right frontal cortex, in the left subcortical white matter, and also in the left parieto-occipital cortex. Now, here in her MRI orbits, they were showed that there were heterogeneous T2 hyperintensities. These are T2 flare hyperintensities heterogeneously, which are present in bilateral orbits. So there were evidence that there was bilateral orbital cellulitis. She was having bilateral orbital cellulitis. But here in the T1 weighted images, in the cavernous sinuses, there were the T1 hyperintense lesions, and these were thrombi which was present either in the cavernous sinus or in the intracavernous portions of the internal carotid artery. In this T2 images showed that there were a large thrombus in the right side, and there was also smaller fragmented thrombi in the left side. The large thrombus is seen in the bold arrow, and in this thin arrow, it is showing that the lateral wall of the cavernous sinus, they are bulging. So there is evidence that this patient could be having a cavernous sinus thrombosis apart from having bilateral orbital cellulitis. Now, the MR angiography showed that there was a fusiform dilatation of the cavernous portion of the ICA, and beyond this, there was complete occlusion. And on the left side, the ICA was already completely occluded. But the angio, which was repeated 5 months later, showed that the disease was progressive, and there was also complete obliteration of the right-sided internal carotid artery. Here in the first angiogram showed that there was fusiform dilatation of the cavernous segment, but the proximal part had been patent. But in the next angiography, the proximal portion had also vanished. But there was good flow in bilateral ACA territories and bilateral MCA territories. After the patient came here, we did an MR angiography of the neck vessels, which showed that there was obliteration of the internal carotid arteries beyond the carotid bulbs. So after the carotid bulbs, the entire tract of the internal carotid arteries had been obliterated bilaterally. But still a good flow was preserved in the bilateral MCA and in the bilateral ACA territory. This was possible because the blood was flowing into the ACA territory and the MCA territory from the posterior circulation through the patent posterior communicating artery. So this child was having a posterior communicating artery, and the posterior circulation, the vertebral artery and the basilar artery, through this PCOM arteries, they were supplying the entire anterior circulation. we did a CT of the base of the skull. There was presence of the foramen lacerum, and therefore this ruled out any congenital agenesis of the ICA. To rule out Takayasu disease, we did a renal angio and both the renal arteries were patent. So the chance of Takayasu disease was very less. The MR venogram was also normal, but this venogram was done when she came to us. At that time, the MR venogram was normal. So this case was a case of orbital cellulitis with infected vasculopathy with bilateral progressive ICA occlusion. Now, this is a follow-up image in which we see that the bilateral residual esotropia is present. Now, what is the mechanism of stroke in both cases? Now, both cases, they had bilateral involvement of the ICA. So there was a large vessel disease is absolutely confirmed. But there is also a possibility of embolic stroke because in the first case, we had seen that there was lesions of varying ages. There were acute lesions, there were subacute lesions, there were chronic lesions. And also in the second case, this important finding that not only in the anterior circulation, but also in the posterior circulation, there were acute infarcts. Now, this could have two explanations. Number one, it could be a large vessel disease that was creating a watershed, deep watershed area infarct because the triple watershed is in the posterior the parietal occipital junction where the three major arterial territories they converge, the ACA, MCA and the PCA watershed. The triple watershed area is in the posterior parieto-occipital cortex. So a large vessel disease with a deep watershed can explain this, or it could be an embolus which had traversed from the cavernous portion of the ICA, this cavernous portion of the ICA through the patent PCOM artery. They could have been embolic phenomena which could have gone into the posterior circulation. So we cannot rule out the occurrence of an embolic stroke. So there was a large vessel disease, and plus minus an embolic phenomena is also a possibility. Now, this internal carotid artery occlusion is a bilateral internal carotid artery occlusion is a rare phenomena, but it has been described with sickle cell disease. It has also been described following Mycoplasma pneumoniae infection in a child. It has been, there are two cases of Mycoplasma pneumoniae infection with resultant bilateral internal carotid artery occlusion. One was in the Turkish Journal of Pediatrics, and another one was in the Pediatric Neurology. And this second case was from was an Indian case report. Now, this is another case report of cavernous sinus thrombosis, which was complicated by carotid artery occlusion. And there's another report where there was reversible narrowing of the internal carotid artery following cavernous sinus thrombosis. But our case was different from this case because there was a progressive arteriopathy following cavernous sinus thrombosis, and there was progressive obliteration of bilateral carotid arteries. Now, in this study, which showed that the different causes and diverse outcome of the extremely rare septic cavernous sinus thrombosis complicated with internal carotid artery stenosis, here the authors described two cases where the cavernous sinus thrombosis occurred after sinusitis, and in one patient it was complicated with death, but in another patient he had complete recovery from the septic cavernous sinus thrombosis and internal carotid artery stenosis. Now, this is the largest case series where they describe 10 patients of cavernous sinus thrombosis and carotid artery narrowing. Among 10 patients of cavernous sinus thrombosis, all the 10 had the carotid artery narrowing, and in 5 cases, the narrowing were bilateral. In 2 cases, there was bilateral occlusion of the carotid arteries. 6 patients had infarcts, but the rest patient did not have infarcts despite having bilateral carotid artery narrowing. And the organisms in this case, the most common was Streptococcus, followed by Staphylococcus, and the last common organism was Zygomyces. Now, in the vascular effect of infection in pediatric stroke study, the VIP study, they described arteriopathy as an imaging appearance of an in situ arterial abnormality. It could be stenosis, irregularity, occlusion, banding, pseudoaneurysm, dissection, or flap. which was not attributable to an exogenous thrombus and not considered as a developmental variant. In the first case, the arterial abnormality was a pseudoaneurysm, and in the second case, the arterial abnormality was initially the thrombosis of the bilateral the cavernous portions of the ICA, and later it was followed by occlusion. Now, according to the VIP study, the subtypes of arteriopathies were arterial dissection, the focal cerebral arteriopathy, the dissection type, the focal cerebral arteriopathy, the inflammatory type, the diffuse or the multifocal vasculitis, it could be primary or the secondary type. It could be primary or secondary moya-moya disease, the genetic or syndromic arteriopathies, iatrogenic, or the others. Now, in the cascade criteria, there was, after the VIP study, there was a consensus-based classification of childhood arterial ischemic stroke. And in this cascade criteria, the cascade stands for childhood acute ischemic stroke, standardized classification and diagnostic evaluation. According to this cascade classification, this pediatric stroke could be classified into a small vessel arteriopathy, unilateral focal cerebral arteriopathy of childhood. It could affect the anterior circulation without collaterals, of the anterior circulation with collaterals, the posterior circulation. Or it can be bilateral cerebral arteriopathy of childhood with or without collaterals. It could be aortic or cervical arteriopathy. It could be a dissection variant, Takahashi arteritis, or fibromuscular dysplasia, or it could be cardioembolic or other multifactorial. Now, if we follow the temporal course, the arteriopathy could be progressive, in which 3 to 6 months after the initial event, the same modality of imaging shows a progressive lesion. It could be a stable variety of arteriopathy where the same modality of imaging 3 to 6 months later does not show any progression, or there can be reversal of the arteriopathy, or it could be intermediate variety where the imaging was not repeated. Now, according to the VIP study, the categorization of our cases where diffuse or multifocal vasculitis secondary to infection, which in both cases were orbital cellulitis in our series. And according to the cascade classification, it was bilateral cerebral arteriopathy of childhood without collaterals. The case 1 was reversible because the pseudoaneurysm disappeared after antibiotic therapy, and the case 2 were progressive because initially the left-sided carotid artery had been obliterated, and the right-sided post-cavernous sinus, it was obliterated, and in the follow-up images, both the internal carotid artery beyond the carotid bulbs, they were obliterated. So in the second case, it was bilateral progressive cerebral arteriopathy. Now, I put this slide to show the comparison between our case where there were no collaterals and another case where there were plenty of collaterals. So in our case, both the cases, they were without any collaterals, the bilateral arteriopathies which were without any collateral circulation. So the take-home message for today's presentation is that pediatric head neck region infections are prone to complicate with arteritis and its sequel. Now, if there is any pseudoaneurysm formation, it usually presents with mass effect or cavernous sinus syndrome, but the brain ischemia feature that is rarely reported. An antibiotic therapy may not resolve the arteritis completely, and if there is persistence of the pseudoaneurysm, despite the complete antibiotic therapy, an endovascular or an open surgical management is mandated. Now, I ask the expert madams to take on, and if there are any questions, I am ready to answer them.
Yes, there are a few questions in the chat box before you go to the experts. There were 1 or 2 questions as to why you considered the possibility of a Takayasu arthritis, and also what was the management that you have given for the second child. Did you consider giving anticoagulation? And such questions have been asked. So can you just...
Yes. In the first thing is that we consider the Takayasu arteritis as a remote possibility because there were obliteration of the large vessels, which was progressive. Usually once the infection has healed, the arteriopathies usually do not progress. But in this case, the arteriopathy was progressive. So the large vessel obliteration were occurring. So we considered that there could be a remote possibility of a Takahashi arteritis. So we just investigated to see whether the renal arteries were also involved. But in this case, there was no involvement of renal arteries. So we persisted to our diagnosis that it was a progressive infection-associated vasculitis. Now, this patient, it was initial treatment was not treated at our hospital, but it was treated at some other medical college. That their records show that there was the anticoagulation was not given. Rather, the patient had been put on aspirin, and when we were following up the patient, we continued on that aspirin, and we continued the anticonvulsant therapy, and we continued aspirin. And in this case, aspirin has to be continued for quite a long time, for a long-term therapy. When we saw the case, there was no point of giving anticoagulation because the arteries had already, they were already obliterated. So we continued on an antiplatelet therapy.
Okay, fine. Thank you. Now I call upon the experts for their comments.
Do you want to, Dr. Suman, do you want to take 3 minutes to show the next case? Because I thought that was very relevant.
Yes, madam.
Yes, you can go ahead.
Yeah. Quickly, I mean, just that, because that is something important which everybody sees more in practice, you know.
Yes, madam. The next case is not about, the next case is also about the infection-associated vasculitis, but it was not related to orbital cellulitis. Now, this case was a 1.5-year-old boy. He was having a normal growth and development. He had a history of fever for 7 days and excessive irritability. The seizure started from 7 days onwards. It was a left focal seizure with a secondary generalization. Following seizures, he was admitted to the hospital. He had progressive downhill course. He became obtunded with tonic posturing of all 4 limbs. There was neck rigidity, there was bilateral papilledema and bilateral lateral rectus palsy, and the pupils, they had sluggish reaction, and he was having decorticate posturing. Now, the blood cultures were normal in it did not reveal any growth. The blood counts and the renal and liver function tests were normal. The chest X-ray was normal, but there was pleocytosis in the CSF. It was a mononuclear pleocytosis. There was sugar was decreased, and the protein was elevated to 190. The CBNAT was negative, and the Gram-stain, Zn-stain were also negative. The gastric aspirate of a CBNAT was also negative. Now, the patient was started on injection phenytoin, levetiracetam, mannitol, dexamethasone to reduce ICP, and this patient in the initial CT scan had hydrocephalus, so we also started category 1 ATD. The patient developed respiratory acidosis, and we started patient on ventilation. Now, this MRI, it showed a left putaminal infarct. This T1 image. Now, this this T1 image, it also showed that there was left paraventricular and subcortical white matter infarcts. Now, the T2 images, they were showing the hyperintense lesions in the putamen and also in the posterior limb of the internal capsule. The same thing was present in the flare, but the flare also showed that on the right posterior limb of the internal capsule, there were also in the presence of the T2 flare hyperintensities. They were present in the external capsule, in the right internal capsule posterior limb. They were present in the caudate nucleus right side, the putamen, and also in the periventricular areas, and also in the left posterior limb of the internal capsule. The DWI showed that there were bilateral lesions, mainly in the basal ganglia region, in the bilaterally, and also in the periventricular region. Now, here in the angiography, it showed that there was a long segment narrowing of bilateral MCA. The bilateral PCAs, they were also narrowed. The origin of the left-sided PCA was almost invisible. The ACAs, they were also grossly narrowed bilaterally. Now, after 10 days, there was an MRI was repeated, and they were showing that there was a progression of the infarcts, and the infarcts were now involving the rostrum of the corpus callosum. They were involving the parasagittal area, and they were involving the watershed area on the watershed parasagittal area on the left side. So there was progression of the infarcts which were in the penetrating artery territory initially. Now the watershed areas are being involved, which shows that the large vessels are now being involved. Here there is more florid watershed area infarcts. Here there are cortical infarcts, and here on the right side also there is a subcortical watershed infarcts. So bilateral watershed infarcts appeared in the next MRI, which showed that a large vessel vasculopathy is now also occurring. Now, the new angiography, despite treatment, showed that there was persistence of the narrowing of the MCAs. The PCA was now better delineated than previous one, but the ACA still they were persistently constricted. Now, the cerebral infarction pattern in tuberculous meningitis. Now, what could be this? Whether it is vasculitis or it could be vasospasm. Now, here there is a long segment affection of the bilateral MCAs. So the most plausible thing was that it was a vasospasm, because there was a long segment narrowing. Vasospasm is defined as a long segment reversible narrowing in serial computed tomographic angiography or magnetic resonance angiography. But in our case, there was no reversal. There was persistence of the long segment narrowing in our case. But vasculitis is defined as the presence of localized or short segment stenosis or narrowing or beading on CTA or MRA. But in our case, both the MCAs and both the ACA and both the posterior cerebral artery, they were showing the long segments of them, they were narrowed. Now, 40% of the patients of TBM usually have vasculitis, and 15% they initially have vasospasm, and it usually involves the middle cerebral artery, the terminal internal carotid, the basilar, posterior cerebral, or even the internal, intracranial part of the vertebral arteries. The infarcts, as we initially see, in our case, it was mainly limited to the lateral ventricular striate artery territory, which are the branches of the middle cerebral artery. But later, they also go to involve the medial ventricular striate territory. And the perforators of the posterior cerebral artery territory, they come next, and last is the cortical branches. And usually the 41% of the infarcts, they are present in the multiple vascular territories. Now, usually the degree of the leptomeningeal enhancement, they predict the extent of the infarct, because the intense vasospasm is due to the incorporation of these vessels within the gross exudate in the leptomeninges. Now, these leptomeningeal vessels, they show panarteritis, but the larger vessels, they show periarteritis. The smaller and the medium-sized vessels, they show panarteritis, but the larger vessels, they show periarteritis. And in the treated cases, there is fibrous endoarteritis is seen. Now, in the studies which evaluated the risk factors of ischemic stroke in tubercular meningitis, age less than 3 years, convulsions, and hydrocephalus, there were the major risk factors. And 33% patients who were admitted without stroke developed it within 1 month of the development of the tubercular meningitis. Now, this was the preoperative CT of the patient. This was the patient with whom the external ventricular drain was inserted because the protein level was very high. So the initial VP shunt could not be done. And here it was the EVD which was inserted. And now the patient, the EVD has been removed and a VP shunt has been inserted. So this was the end of the presentation. I'm ready to answer the questions.
2 more questions have come up. One is the role of anticoagulation, especially I think for the cavernous sinus thrombosis, whether anticoagulation is required or not. And second is the role of steroids, whether it can improve and reverse the symptoms.
Yes, madam. There is a definite role of anticoagulation in the cavernous sinus thrombosis. This is because there's two schools of thought. One school of thought says that only antibiotic therapy is sufficient for the cavernous sinus thrombosis because in children they are usually due to septic causes. But the second school of thought is that in addition of anticoagulation, it improves the outcome because once the anticoagulation has been added, they thin out the thrombus, and so the penetration of the antibiotics into the cavernous sinus is more. So the second school of thought they say that the addition of anticoagulation, initially heparin and later long-term warfarin, they say that the addition of anticoagulation helps in faster resolution of the thrombus and a lesser chance of any other complications. And the second is that role of steroids. The role of steroids is important if there is associated vasculitis, because it has been seen that whenever steroids have been added in cases of vasculitis, the chances of recovery is much more. Many of these cases, many of these cases of unilateral vasculitis, which we see, they are transient cerebral arteriopathies. So initially they will show focal segmental narrowing, but once they have been treated with steroid, the chances of recovery and the chances of reversal of the stenosis and the reversal of the artery to its previous caliber is much higher in the steroid treated group than in those patients who have been treated only with aspirin without steroids. So in cases who have proven arteriopathy, steroids usually has a role.
Just to add on to it, is there any role for a surgical drainage in cavernous sinus thrombosis?
Yes, madam. The surgical drainage in cases where there is progressive neurodeficits and there is a lack of resolution of the fever, there is progression of the thrombus. In that cases, surgical drainage can be done to remove the thrombus and also, apart from the removal of the thrombus, to remove the septic foci. If it is sinusitis, then a functional endoscopic sinus surgery, or if it is orbital cellulitis, then drainage of the orbital abscess, that also aids in the faster resolution of the disease.
Okay, now over to the experts for their comments.
They were very, very good. Dr. Maya, should I just say a few words before? You want to say first?
No, go ahead, Dr. Shafali, please go ahead.
Okay. Yeah, they were nice cases. All three of them were nice cases. One thing is there that it is important for us to see the imaging becomes very important. And as Dr. Maya was saying, when you have focal deficits, you have to be very careful about it, and we need to have this vessel wall imaging and doing for these mycotic aneurysms. We also had a case, in which when we were giving antipyogenic, therapy, it was not getting resolved. And there was some sinusitis, and as we got the ENT people to do the drainage, and we got the tissue from there, and that growth aspergillus. So then the child improved after voriconazole, and the child had cavernous sinus thrombosis and internal carotid thrombosis. And it is always wise in the initial part to start with the heparin, that is better to be started in the beginning. And yeah, steroid has an issue. We generally don't give steroids in the kind of infection. Yes, of course, not in the tubercular, but the other ones. And the anticoagulation and all has to be started earlier. Somebody did write that if you don't have MRI, whether to start. So we'll have to see clinically, but I think the anticoagulation thing has to be kept in mind. And TBM, why I wanted him to present that case is because, TBM, we need to act very fast. Sometimes you may have the TBM infarcts can become very malignant, sometimes. And then you may have suddenly midline shift and all that. It can be life-threatening. We have seen patients waiting in the emergency for admission, and then you suddenly find that they've just decompensated. So we have to have a high index of suspicion, but there were nice cases of infections and associated with the thrombosis and all. So it's very important if the case which I was talking about, that if the resolution was not there, the child did not improve with the antipyogenic. So, and that is why we tried to get and there was sinusitis, so we tried to get the nasal scrapings and the, got the aspergillus, and the child improved. Dr. Maya, your comments, please.
Thank you, Dr. Suman, for those interesting cases. Just one question regarding that second case. There was one image which showed bilateral acute infarcts. That was done during the acute stage because you saw the child a year later, isn't it? The second case?
In the second case, the bilateral acute infarct, that was in the acute state. That was not the MRI which we did at our center. It was at that acute stage that was done, that MRI.
Okay. But the child did not have any deficits when
child had left-sided hemiparesis. She was, and 1 year later, the power was 4 minus by 5.
Right. Yeah, so I think, the acute arterial ischemic stroke in a child in our kind of a setting, I think infection is still high on the list because this, of course, I think the stroke was probably due to a direct invasion of the vessels, vasculitis due to a direct invasion, because in both the cases you had orbital cellulitis. In the third case, you have the vessels bathed in the exudates, causing the vasculitis. But in a lot of cases, we see the infection is, like, for example, dengue causing stroke, mycoplasma pneumonia causing stroke, varicella zoster causing stroke. In these cases, it's you just have the systemic infection, and then you have focal cerebral arteriopathy causing the stroke. So in our setting, more than the usual cardioembolic and what do you call coagulation abnormalities, infection-associated stroke is still a very common cause of arterial ischemic stroke in our Indian setting. And again, this role of aspirin versus anticoagulation is very controversial. But like you said, there are various schools of thought, and it varies from one center to another center. But the basic thing, I think, is definitely there is an element of inflammation going on. So I guess antiplatelets definitely will help. Anticoagulation, I guess you take a call, depending on the risk versus the benefit.
Yes.
I just wanted to mention that sometimes you may have fungal even in, sorry, you were saying something, Dr. Maya. You were saying something, Dr. Maya.
No, go ahead, Doctor.
Then the case I was saying was, I was talking about that fungal case, that child was immunocompetent. So I'm just saying that we have to keep a high index of suspicion if normal antipyogenic stuff is not getting well. And also, have a high index for ATT also, because in many situations, it's still very common for us to have. And yes, the debate between anticoagulation and is there. It's always there, whether you want to give heparin or you want to start aspirin. That is always there. But we have to take it individualized. But, when you're having cavernous sinus thrombosis and all, we'll prefer to give an heparin in that situation. When you have extensive thrombosis in the cavernous sinus, that will be there. Yeah, please.
Madam, in the post-COVID era, we got many adult patients to see where mucormycosis was causing vasculitis. So fungus should also be kept in mind.
Just to add on to that, in cases where there is a meningitis especially, and when we do a lumbar puncture, if you are not taking enough care, the post-LP, iatrogenic mycotic aneurysms can also happen. So the maximum cases of mycotic aneurysms occur mostly as iatrogenic, and there have been case series on that. And second thing is that in your first case after antibiotics, the mycotic aneurysms resolve. So just to, because there are students here, I think DM students are here in the audience, just to highlight what is the carotid, this cavernous sinus aneurysm, no? So there is I see aneurysm in the cavernous sinus. That is what I meant. So in those cases, the management is different if it is idiopathic as well as if it is traumatic and infective, no? So if the antibiotics is not resolving, what is the next line of management for that?
Yes, ma'am. Madam, if the antibiotics have not resolved the aneurysm, then we have to go for some intervention. Now, what actually should be done, it will depend upon the site of the aneurysm and the size of the aneurysm and the size of the neck of the aneurysm. Now, if it is the neck is narrow, then a simple coiling can be done. But if the neck is wide, then we have to go for a flow diversion, or we can have to go for a stent associated coiling. But if the infection is not being resolved by the antibiotics, then if it is mainly a lower down in the cervical portion of the ICA, if there is an aneurysm, then a parent artery occlusion, and we can have to sacrifice the parent artery, because a direct coiling in that area might not resolve the in an infected area coiling, it will result in spread of the infection. So in that case, a parent artery occlusion should be considered as a possibility, although a preoperative DSA should show that the opposite sided ICA is feeding the anterior circulation of that side well via the communications, that is the ACA, that ACOM artery, there is a good flow from the opposite side to that side. Only then we can do a parent artery occlusion.
Because the idiopathic aneurysms, usually because the tunica media is so tough, the cavernous sinus, they don't usually rupture. They can go into a very giant size also. And often they are managed conservatively by the neurosurgeons. But in case of infective aneurysms, as you mentioned, there is a chance for a carotid cavernous fistula or a eroding of the sphenoid bone, producing a fatal epistaxis. In such cases, we need to treat aggressively with antibiotics, and if it is not resolving, you have to go ahead with interventions in such a case.
Yes.
So, Dr. Naveen, any more comments, Dr. Naveen or other panelists? Dr. Naveen or Kavita?
Nothing from my side, but I think it was a very good session, and Dr. Suman really presented these cases, which showed us the spectrum of all the vascular complications that can happen, and a very nice description of the neuroimaging for the students as well. So thank you very much.
Thank you, madam.
Dr. Naveen, you want to add anything more?
No. Thank you.
Okay, thank you, Dr. Suman. There was a lot of learning points as well as practical session on how to manage this infective cases. And also the experts also added their points also very well taken in this session. So it was a wonderful session. Thank you, Dr. Suman, Dr. Shefali, and Dr. Maya, and also all the delegates who have participated. Thank you.
Thank you. Thank you.
Thank you, and good night to all.
Thank you. Bye. Bye.